All right, so hello everyone. Thank you for joining us tonight for our nationwide panel on geriatric dentistry, hosted by the Student Professionalism and Ethics Association. My name is Caitlin Loo, and I am the outgoing Canadian Regent for SPEA. We have the privilege of being joined by a panel of 5 experienced dental professionals who will be speaking about their experiences working with geriatric populations and sharing their insights into how we can provide optimal care for these patients. Tonight, we will hear from Dr. Christian Caron, Shaheen Husain, Mary Bertone, Raj Bhargava, and Nicholas Tong. Just a few reminders before we get started. We encourage you all to submit any questions you have for our panelists, as we will have a Q&A session after the panelists' presentations. You can send your questions by posting them in the public chat or sending them privately to one of our team members, so Eunice Park or Eva Kieran. We are also holding a draw for Amazon gift cards, courtesy of the American College of Dentists. So thank you to them for their support, and happy Thanksgiving to any of them joining us from the States. To enter the draw, please visit the link, which will be posted in the chat, and then stick around until the end of the event when we will announce our winners. I would now like to give a land acknowledgement. So we acknowledge that our universities are located on the traditional lands of the Indigenous peoples of Canada. We acknowledge that Western University is located on the traditional lands of the Anishinaabe, Haudenosaunee, Lenape, and Tawanaran peoples on lands connected with London Township and Sampa Treaties of 1796 and the Dish of One Spoon Covenant Wampum. We respect the long-standing relationships that Indigenous nations have to this land, as they are the original caretakers. We acknowledge the historical and ongoing injustices that Indigenous peoples endure in Canada, and we accept responsibility as public institutions to contribute towards revealing and correcting miseducation, as well as renewing respectful relationships with Indigenous communities through our teaching, research, and community service. So the way it's going to work tonight is that each of our 5 panelists is going to give a presentation, and then that will be followed by a panel discussion. So without further ado, I'd like to introduce our first panelist for tonight, Dr. Christian Caron. Dr. Christian Caron graduated as a dentist from Laval University in 1985. He started his career in Quebec City private practice for 9 years. He was then recruited by Laval University on a tenure-track position in the dental faculty. He left for Boston in 1994, where he was trained for 3 years in geriatric dentistry and 5 years in research. In 2000, he obtained a certificate in oral epidemiology for epidemiologic and statistical research and healthcare management, a certificate in geriatric dentistry for biomedical research, patient care and teaching, and a doctoral degree in oral biology research from Harvard School of Dental Medicine. That same year, he started the first 2-year graduate program dedicated to geriatric dentistry in Canada, which still trains students today. In 2007, he founded the Center for Excellence in Oral Health and Aging. He's an active member of the Network for Canadian Oral Health Research and has served on the steering committee since 2016. He's still an active member of research networks in Quebec and is a researcher in the CHU de Quebec Research Center. He has been a full professor since 2011 at the Faculté de Médecine Dentaire de l'Université Laval. He is the chair of the Department of Dental Medicine in the CHU de Quebec. He also delivers dental care in hospital settings, nursing homes, and at domiciliary with mobile equipment to underserved elderly with a loss of autonomy. Please welcome Dr. Christian Caron.
Thank you for inviting me to your meeting. You know, since English is not my first language, I may do some mistake, and I apologize for that already. But I think I should do all right. Anyway, so what I want to talk to you about geriatric dentistry, you know, it's for me, it's a long story, because when I start to go in that field, I didn't know in what I will face then now, because I didn't know really what was the people that I would be treating later, and then when I got to my training, I knew then what I was facing. So now the people that we are treating are vulnerable elderly, but when you're young students in school and you have seen only patients that are cooperative, so you do not know really what you will face when you will have to treat them. So in a short story, with experience with that population, you have to be very humble on what you need, what you have to do, and what you can do with this population. And one thing that is very important to remember is that these people, need care, but the other thing that you have to think before treating them is know what you'll be able to do, because we're working with very often uncooperative people. So when you do your plan, your treatment plan, always remember that to put on the plan what you think that you'll be able to do. And the more the loss of autonomy is getting to the people you're treating, the simpler the treatment should be, because it's very hard to start something and not being able to finish it. So as I said, we have to be humble with these people, and as the cognitively lost get in, you need to be, the treatment should be simpler. The other thing is, we are also looking at the people that do not have the right to, sometimes they are not deciding for themselves. So also you have to deal with or the family or the legal I don't know how to say in English, the legal person who take the decision for them. So that's another point that you have also to remember, that when you're facing a person, you're dealing quite often with the family or the people. So you're treating more than a person, you're treating not a lot of person, but people that work around that or help the people that you're treating. The other thing that you are also understand, and I will say to Kathleen to stop me if I go too far with my time, it's that these people are impaired. Always remember that these people have lost, a lot of people in nursing home have a loss of hearing, and they always see as like they are in a tunnel. So when you're treating them and you are talking to them, remember that they sometimes have the hearing problems. The other thing, if you're getting from the back to the front from there, if you don't remember that they see as a tunnel. So if you touch them without being in the place that they are viewing, that able to view, they may be very surprised, and also then you can lose all the cooperation that they can give it to you. So remember that they are impaired people. They are people that need care, love, because you are to be very gentle with them, and the tone of your voice are very important to have them cooperate also, and they has to feel like you're caring for them, you're cuddling them. I don't know if the right term, but they need, that they feel the interest they have to them. The other thing, the more that they get impaired or cognitively impaired, the more also they may not be all there when you're talking to them. So you have also to tell them, look at me. You have to develop eye contact when you talk to them. Otherwise, they may not understand what you say, or they are away from what you're saying. They won't integrate it. So you need to get them to be sure that that you are the eyes to eyes contact when you talk to them. The other thing that I would also ask to tell you from my experience is that the other thing is, you may not be able also to have the surrounding people take care as you would like, as daily oral care. And you will feel that a lot of the mouth looks with a lot of biofilm and tartar that are building, and it's not easy to take care of another people. So we want that oral care would be increased, but also it's not always easy to do that for another person. So the carer, sometimes they do what they can do, not always what they want to do. So that we need also to have them get some training also if we can. But when you're able and not cognitively able, you will be more you will be more able to take care of your mouth, but much better than if other person will brush your teeth. So what is my point there is that we may, on the long term, for research, getting to chemotherapeutic agent that will help to make the biofilm less aggressive on the teeth. So like the bacteria will find product that will lower the acidity of the plaque. So you will get less caries, because caries is very, very rampant in that population. And I would say that somebody that have their that they get sick, like they get the dementia or the cognitive loss, sometimes when you can see in 2 years a full destruction of the mouth, almost. You can get some very, very, very bad teeth very, very, very rapidly. So that's why we will need help in research, also looking at chemotherapeutic agent that will slow that process. We will need training for people caring for them, like to daily care, but not only daily care, we also need some tool or train people to detect earlier the oral problem, so they can be taking in charge more rapidly. So it will be more conservative treatment that can be done then, and easier to people that are not cooperative, who are uncooperative. I think I've talked a lot. I don't know if it was understandable, but I think the only last word that I would say is geriatric dentistry. There's 3 fields very important. Be able to understand medical situation of the aging patient, knowing your pharmacology, because you are dealing with a lot of medication, and also learning how to deal with the declined cognitive state of the person. And if you're able to do that and get a hold on over that, I think you'll be good to treat these people. So thank you very much. I think I've talked enough.
Okay, perfect. Thank you so much, Dr. Caron. All right, so next we will move on to Dr. Husain, and I will introduce Dr. Husain. So Dr. Husain is a general dentist on staff at the Department of Dental and Maxillofacial Sciences at Sunnybrook Health Sciences Center. Her clinical activities are primarily focused on providing comprehensive dental care for the frail, elderly, and medically compromised. Dr. Husain has been on staff since 1993 as the head of the Division of Geriatric Dentistry, a clinic dedicated to the care of the frail, elderly, veterans, and the medically complex. She obtained her bachelor's degree in dentistry from Guy's Hospital at the University of London in the UK. She holds a master's degree in Cardiology from the Faculty of Dentistry at the University of Toronto. Dr. Husain is retired as an assistant professor from the Faculty of Dentistry in 2018, where she taught cardiology, preventative, and geriatric dentistry at the graduate level. She has over 35 years of experience in treating seniors that have complex dental and medical issues. As part of an interprofessional team, she has developed guidelines in providing daily oral care for the residents in long-term care. She is interested in prevention of dental caries in those at high risk, such as those who are cognitively impaired and have medical complex conditions. Please welcome Dr. Husain.
Thank you very much. Thank you for inviting me here for this panel. As you know, I've been practicing for well over 35 years, and most of it has been with treating seniors or the frail elderly, and it has been wonderful for me. I've really enjoyed providing care for this population and have learned a lot. And it has been challenging as well as rewarding. The challenges that we faced because people are living longer, because of the increased medical technologies and knowledge, people are living to the 9th and 10th decade. And because of our good oral hygiene practices while they were younger, most of these people are maintaining their teeth, their dentition. So it's become a real challenge to kind of extend the life of these teeth. And often when we're faced with treating this population, it can become very overwhelming. And the most important thing, I think, is to, as Dr. Caron said, is to understand your patient, to understand where they are in their medical history. You have to really do a very thorough medical history for them. You have to take into account their biological age, that you have to look at their current and acute and chronic conditions that they have medically, and you have to try and provide a safe environment for that patient while you're doing the work for them. And one of the most difficult things as a dentist when I'm treating this population is to try and keep it very simple. We are taught as clinicians to do what we can to restore the dentition. And so I think what happens is that we try and do a lot more than is possible for this group. So you have to look at what you're dealing with. So in comparison to someone who's in their 30s, 40s, 50s, and 60s, the population over 85 has diminished in everything. Cognitively, they have diminished in actual physical, psychological, all of these issues, as well as their dentition, their jaws, their bone, everything is reduced. And so you're working with a sort of situation which is very, very hard and complex, and it can become extremely complex. So the way I think, to approach anything to deal with these complexities is to use some projectional ethics. And the way to look at it is, once you've looked at all of these issues and have come up with a diagnosis and then come up with a treatment plan, you have to see and ask this question of yourself. If this was my grandmother or grandfather, what would I do for them? And if you apply this logic, then you will do the best you can with a lot of empathy and sympathy and skill. And what has happened is that, as Dr. Caron has also said, is you're not just dealing with the patient, you're dealing with all other situations. You might be dealing with a POA, power of attorney, you might be dealing with the family. So when you're doing an assessment for that patient, you have to consider these factors as well. You have to consider whether they how do they look when they come in? This is a very important thing with any patient that you see. When they walk into your operatory, you see how they are. You see whether they're frail, whether they can stand on their own, what sort of challenges that they have. And that should give you an idea of what they can handle when you're trying to come up with a treatment plan. And often you'll have to consult with their physician, consult with their psychiatrist, consult with their social worker and family to get a whole picture of where this patient is coming from. And so you have to look at other psychosocial considerations, such as how emotionally stable they are, their cognitive impairment, what is their motivation, and do they have family support? And lastly, do they have financial support to do all this wonderful treatment that you're going to be doing? Often, the typical patient that's frail and elderly coming on to cognitive decline is one that hasn't been to see a dentist for quite a long time. And they are introduced to us as an emergency, maybe on an emergency basis, where trying to take care of them is a little bit challenged. So we have to take the whole of that and then come up with a treatment plan. And once you've done the full assessment and you've done the full examination, then you look at what you can do. So some of the common things that in this age group that you will see a lot of are fractured teeth. That is one of the most common emergencies that we have, is the tooth is broken. We have recurrent caries under these wonderful bridges that they've had for 20, 30 years. The whole mouth is disintegrating very fast with recurrent caries, coronal caries, root caries, dry mouth because of the multiple medications that they're taking. So there's a whole challenge that we have to face when we try and come up with treatment for these patients. And as Dr. Caron also said, we have to try and keep it simple. And that is a very hard thing when you, as a dentist, have graduated and you look at disease and you say, I have to treat it, I have to do something about this. But many times it may be detrimental to the patient for you to do this. For example, if you have a patient that has multiple fractured teeth, retained roots, and bombed out mouth, it's not a good idea to consider full mouth clearance because you have to factor into account, how is this patient going to deal with having no teeth? The teeth are broken down, but the teeth are there. They're not in pain. And most of the time, people are not in pain. They just might come in because of fractured tooth, or they might come in because they have a bridge that's a fixed bridge that's a bit loose, or the dentures don't fit, that kind of thing. But it becomes a bit of a challenge to try and figure out how to manage these patients because it's very, very complex. The complexity of their medical history, complexity of their cognitive impairment. Also, we're worried about whether they can sit in the chair long enough for you to treat them, they can keep their mouth open, all those kind of things, whether they can come to your appointments because they're frail, they're dependent on family members bringing them, and mostly families are busy with taking care of their own and working, things like that. So it becomes a multifaceted problem to try and deal with this case. So my three things to say is that, first of all, our goal of our treatment would be to try and preserve and maintain their natural dentition as long as possible, and to prevent infection if we can, and restore function if we can. So there are times when patients are coming in and they are too frail, too sick for them to have teeth extracted. So how do we deal with that? We deal with that with pharmacy by using medication, antibiotics, and painkillers to try and stabilize the situation. So it's not a perfect world when we treat with geriatrics. It's not one that you have to try and maintain a certain level of function. It's what's comfortable for that patient. And once all the teeth have gone, we have to try and maintain, the goal is to maintain their oral tissues. So the way to remember when you're coming up, you've got your diagnosis. Often with patients with dementia, you cannot take radiographs. So how do you deal with, and the patient can't tell you, I've got pain, doctor, I've got pain lower on the right side, and it hurts when I eat. Most of the time with cognitive impairment or severe dementia or any kind of dementia, they cannot tell you where it hurts. So you rely on the caregiver to give you that information, that when I touch the face on the right, the patient flinched or there's a swelling. So if you cannot take radiographs, how do you find out where it hurts? You do an examination, and the way to, one of the things that I found out is to go and palpate all the apices of the teeth and see if I get a reaction, and try and come to a conclusion that this is what the situation is, and then this is what the treatment is. So when you're coming up with treatment planning, which is the most difficult thing in treating geriatrics, you should ask, you should ask 3 questions. Question number 1, what does the patient actually want? And this applies to all of your patients. You and your patient's caregivers have to be on the same page. You all have to understand what they are asking of you and what you can do. The second question is, what can the patient tolerate? Can they go through and have complex restorations? Can they go through multiple extractions? And if so, what will be the consequences of all of those treatments? And one of the things that I've learned during all of this time treating patients is that if you try and do too much, you will end up doing nothing because the patient won't cooperate with you. So, and the third question you ask is, what can be really achieved? You can have someone coming in with a dentition that's been there. The patient is 100 years old, so some of the teeth have been there for almost 96 years, and they're worn down. There's tooth wear, there's decay. So what can we do for this patient? The best thing to do is to see if they're, first of all, if they're in any symptoms, you work on their symptoms. Secondly, you kind of isolate what needs to be done and then come up with a treatment plan. So sometimes it's okay to do nothing. So when is it okay to do nothing? First of all, when you cannot get cooperation. So you think, well, maybe we can sedate the patient, and maybe we can have a look once the patient is sedated. But some patients may be too sick to allow us to sedate them. So what we have to do is come up with a treatment plan, and the treatment plan in that case would be no treatment at all, but to do observation. And if something happens and they have an acute infection, then we deal with that infection. And it may be as simple as just giving them antibiotics or giving them painkillers. The second treatment option would be to provide emergency care, and that would be to actually go in there and have to do an extraction and or restoration. Or I found that using silver diamine fluoride has been a wonderful tool for us, and patients with severe dementia, I've just painted it liberally on all their teeth, and it has arrested their caries. Yes, they're brown. Yes, they're black, but at least they're not active caries. And so it's a wonderful tool. The other tool is often when you're dealing with patients with dementia is that you might only have 5 minutes maximum for you to do the treatment. So you might just go in there, excavate some caries, put a glass ionomer, SDF and glass ionomer on there, and that should be okay. The third option for treatment is to do maintenance and monitoring. So if you can't do active treatment, what you can do is you can provide oral care for them, clean their teeth, and we can use mouthwashes if they can rinse. If they cannot, then we have to teach the caregivers how to provide oral care for that particular patient. And often caregivers are very scared when they see broken teeth, when they see huge big cavities, how to deal with the patient. And 9 times out of 10, the patient has no pain, because as you get older, your pulp recedes and calcifies. So that's one good thing about getting older. And the fourth option is to do full comprehensive care, whatever they can. I have a 99-year-old patient who is very fit. He's ambulatory, he's cognitively sharp. He wants to have some crowns put in so that he can have a denture that fits really nicely. So we're going to do that for him. And then we have somebody who's in their 70s with severe dementia that cannot make a decision for that. And so we have to be really careful on the kind of care that we provide for them. It's very difficult to talk about geriatric dentistry in 8 minutes, but I'm just giving you a little bit of an overview. And so basically what we have to do when we're treating these this population is that we have to be sensitive to their medical, functional, behavioral, and situational status, and try and treat them and without so the treatment that we provide for them will be of benefit to them and be tolerated by them. So that is about, I think that's all the preparation that I've done. So thank you very much.
All right, thank you so much, Dr. Husain. I'd now like to ask Eunice to join us on camera. There she is, and she will be introducing Mary Bertone from the University of Manitoba. So go ahead, Eunice.
Professor Mary Bertone is an associate professor in the School of Dental Hygiene at the Dr. Gerald Nisnik College of Dentistry, Rady Faculty of Health Sciences at the University of Manitoba. She has worked as a dental hygienist in a variety of settings across Manitoba, providing care in long-term care facilities, northern and remote communities, and community-based private dental practices. She still provides oral health promotion, education, and dental hygiene care in Churchill, Manitoba. She is strongly committed to teaching, to community service, and to finding unique ways to combine these two realms together. Professor Bertone currently serves as Director of the School of Dental Hygiene, President of the National Dental Hygiene Examination Board, and Chair of the Educators Advisory Committee to the Canadian Dental Hygienists Association. Mary believes in lifelong learning and is currently a student at the Doctor of Science in Rehabilitation and Health Leadership at Queen's University.
Thank you so much. Thanks for that introduction. And I feel honored and privileged to be speaking with you this evening. And it's so great to hear the other panelists. And I haven't been working in long-term care as often. I still do it, but not as often. And when I started my career in dental hygiene, I was working in long-term care, and that was really my primary area of focus for dental hygiene care. And I had to learn very quickly what to do in these very challenging and difficult situations when providing care. And so with that, we also were very involved. I worked for the Center for Community Oral Health, and I worked in the health promotion unit, and had colleagues who were very passionate about improving oral health care in long-term care, especially, but for older adults, even our community dwelling. And so very involved in research, and also in developing resources and doing caregiver training for what we call in Manitoba healthcare aides. And so have been very involved in that and have learned a lot in, being on site and working alongside on unit and that. So it definitely still is a passion, and I don't get to do it as often, but I will advocate as often as I can and whenever I can. So tonight, my perspective maybe will be a bit different. I'm going to be talking about how do we go about putting it in perspective, and how do we be that advocate for, I'll say seniors, older adults, and I might even throw an elderly in there. So just so you know, I'm using it interchangeably this evening. And so I have always wanted to, how do we connect with policymakers, with administration within long-term care facilities, with those who are involved in programming for older adults? And how can we really make that connection to, really see and feel, the challenges individuals are facing? And so I'm going to share a little story that I tend to sometimes give to really put things into context. So maybe we'll start with that this evening. So it's about the who. So the next time you go to brush your teeth, I want you to pause, and this is even for yourselves as students, just to kind of maybe put it back into context of how things can be a challenge. So I want you to pause and think about what you are doing. Brushing your teeth is easy. You have a toothbrush and you have toothpaste. The act of brushing is simple and straightforward, and it only takes a couple of minutes. In fact, it's so easy and ingrained in your daily routines that we take for granted what we even do. But what if you couldn't brush your teeth? Probably your first thoughts would be around vanity. What would people think? Does my breath smell? You might even start to avoid people because of it. With more time passing, without the simple ability to brush your teeth, your oral health would deteriorate. You might develop uncomfortable and challenging oral health issues. And with time, maybe even larger systemic oral health issues. Just imagine how impactful it could be to your life and ultimately to your quality of life if you couldn't perform the simple act of brushing your teeth. In fact, this is not just a thought experiment for many seniors. It is reality of their living situation. Many seniors simply can't care for their own health, and they suffer for it. And it may not be the top of mind to us, but is top of mind to them. So it's putting into perspective how challenging the simple act of, daily care can be. And so when it comes to that reality of, why is this so important? So we know the reality is that when it comes to oral health, it is, we're going to pay, right? In the end, either you pay to cover the cost of effective preventative oral health care, or you pay through the effects of deteriorating oral health, overall health, and quality of life, and the expensive healthcare costs are responding to this deterioration. So if we're going to pay either way, you have to honestly ask yourself, where would the investment be more effective and impactful? And so we go to then looking, so what can we do? Are there models of care that we can follow? So, the cost of providing care, as is mentioned by the other panelists, depends on, what the individual is going to be able to tolerate or be able to have. But we also have the cost of, to just the general ability to enjoy life. And so we can look at the existing models of providing oral care, but maybe it's time to look at new models of providing service, and maybe looking at other ways that we're going to be able to do it, and working as a whole team to address the issues for older adults. And I really enjoyed the fact of there are new ways of doing things, that we could look at SDF and look at preventative ways as well. And so I think it's just time that it has been challenging, and COVID has really put a stop to our ability to even provide care and long-term care in some incidences. So we got a lot of work ahead of us, but I think that there's always that passion and that ability to want to do better. And so when we talk about mouth care training programs for the care providers, especially in long-term care or in assisted living or family caregivers, so we also include family caregivers, they are the ones that are potentially responsible. We need to figure out how can we help those providing care, and that how can we do it with a, a cost-effective strategy, and and find that right answer. So we know, though, if you look at the literature, that implementing a mouth care training program certainly improves oral status of seniors, but is it enough, and does it sustain for a length of time, or is it a short period of time? So that's where the challenges can come into play. So I think that we always talk about, caries is a multifactorial process, and there's lots of different things that are involved, right? It's beyond, we want to say it's the simple act of doing daily care, but we know that there's a lot more other things that are involved. And so there's the ability to provide care, the ability to cooperate for care, the chronic health issues, the polymeds, and there's it just becomes layers on layers. So then what would be the success of implementing an oral health care program? So then that's when we have to pause and look at what are the barriers within a facility. What would a program face? So, what are those challenges? And they're well documented, right? If everybody loved to be in other people's mouths, we potentially wouldn't have jobs, because it would be so attractive to so many. But for those that aren't ready and aren't able to feel safe when practicing daily mouth care, it can be a huge challenge. And so sometimes we think that we develop a program within a facility, or and then we think, oh, we figured it out, we've designed, it will work. But we also forget, though, that there's always a culture that's involved in it. And there's a culture that is within any facility, and that culture changes. So whatever works on one unit, on one floor, may not work on the next floor. And so that's really getting to know those individuals who are providing the care, and who they're providing the care to is very different. So you go from one unit to another, it's very, very different. And so sometimes you need to be able to flex and adapt to being able to do that. And if the supports aren't in place, then it becomes a very hard challenge for those who are providing care. So that's where we need to develop the knowledge and skills for those who are providing care. And again, it's not just, professional caregivers, it's also family that's involved. And so, as we know, people are staying in their homes longer, and utilizing supports in the community. And sometimes it's even working within a community to provide to those supports. So again, when we're developing this healthcare model, we're aiming at promoting comfort, maintaining oral function, and improving that quality of life. And so it is key that the daily care plan is individualized to that person, that there's tips and tricks on how to, safely provide that care. What prevention care can we provide? Can we think outside the box of what maybe would just, looking at providing that comfort care? And a lot of times it is comfort care that they are seeking. And especially those at end of life also are so key and to receiving mouth care. We believe in quality life to end of life, and providing that mouth care, that moisturizing to the end, provides that graceful exit of life. So we need to continue to work interprofessionally and work with our colleagues in the other health professions, so that they also understand what we're able to do and what we can do to provide improved health for those that they're caring for. So working together, sometimes there's that disconnect between dentistry and the other health professions, because there may not be so understanding of what we're able to do, and sometimes we're not so understanding of what their challenges are to provide care every day, and understanding the challenges that are within facilities that we may have not taken into consideration. And so really working alongside our colleagues to figure out what could really work for that facility, for that unit, and not forgetting that. So We always like to, recommend, of course, from any profession, it would be great if we could have a dental hygienist that is working within especially a long-term care facility or other health programs. And sometimes we have had the luxury. So we launched a research project in Manitoba where we had 2 dental hygienists that worked within the facility, and they were there to provide the mouth care training, and they were there as a resource. And so whenever there was a challenge, they could call upon the dental hygienist, and the dental hygienist was there to be able to support and provide that additional training that might be needed for certain individuals. We're also able then to recognize individuals when we were doing our screenings that were at great risk. And so we were able to work alongside with the healthcare providers in that facility. So we did get to see a great change. We also got to see that the residents of that facility who were higher functioning and just didn't have somebody to advocate for them to, actually get their dentures that they needed. And now we were able to advocate and for them to come back and give full smiles. That, there's nothing so rewarding as that. So it is a very challenging field to work in, but it is also, I think, one of my most rewarding areas of that. I've been able to learn so much in providing care to older adults, and especially those who have had a very interesting life. And sometimes I have been the only person that they have been able to have a visit with in a very long time, because there isn't any family that's close to them. And so, that visit to coming to the dental clinic was special to them in that they were receiving care, but they were also receiving a conversation and some time spent with someone else. So always remember that it's not just about us providing care. It's even a part of the social part of it. So. And then we also find that it's very important that that everybody has an oral health assessment, and so that a proper screening is done by a dental health professional, an oral health professional, so that we can have that baseline of what is happening and what potentially could be what restorative needs need to happen, as well as what dental hygiene needs need to occur. And then that anyone that's working within a facility or in a program, that there is mouth care training for those individuals, and actually hands-on experience on doing it, so that every time I would go to do mouth care training in a facility, and they would ask me to do a hands-on one, and I'm always happy to do it, but I always knew I was going to get the most challenging, the most difficult resident that they had. And you know what I mean? Of course, it was challenging, but I welcomed it, because I wanted them to see what the end results would be, and make believers of them as well, that we can make a difference. And it might be a unique way of doing daily care, but we can do it. We also need to continue to advocate, and especially within long-term care facilities, we know the challenges that they have been going through recently. And we also know that we need to have better standards of oral health care within those facilities. And, you know what I mean, as well as accreditation standards for long-term care facilities. So our job, besides providing care, is our job to advocate for those that are not able to advocate for themselves. So thank you so much.
All right, thank you so much, Mary. Now I'd like to invite Caitlin Kirkpatrick from the University of Saskatchewan. Caitlin, yep. And she'll be introducing Dr. Bhargava. So go ahead, Caitlin.
Hi, so Dr. Raj Bhargava is a 1988 graduate of the University of Saskatchewan College of Dentistry. He's been a general dentist practice in Saskatoon, Saskatchewan for the past 33 years. He's been providing long-term care dentistry in-house and mobile through a multidisciplinary dental team approach for the past 25 years through a fee-for-service private practice model. He's been providing this care to the home, facility, bed, and hospital-bound resident in all facets of general dental care, along with RDA and RDH assistance. The emphasis of the care provided is on ensuring and promoting the oral health through treatment of dental disease, focusing on prevention of inflammation, infection, pain, and rehabilitation as needed. This is then followed up by regular hygiene maintenance on a frequent basis, which is the crux of the approach. Thank you.
Great, thank you very much for the introduction. And as Ed mentioned, I've been doing long-term care dentistry now for about 25 years, and I'd just like to give you my sort of experience and scenario of how I provide the care, and then if there's any questions after, I'd be more than happy to answer them for you. So 20 years ago, we started with a pilot project in 3 long-term care homes to just research, demonstrate and quantify evidence of oral healthcare needs for government lobbying purposes. Because anytime you want to ask the government for money, you have to show them, is there a need? Is there a need, and how much of a need is there, so that they kind of can have an idea of what to say no to. So, you know, as expected, we found an average care need of about $200 to $300 per resident, and that mainly included hygiene, basic restorative, minor oral surgery, and removable. Now, since the majority of our long-term care homes are under the jurisdiction of our provincial government, Ministry of Health, the ability to be able to provide dental care is achieved by obtaining privileges through our Saskatchewan Health Authority. Our model of care is to provide dental services through private practice, providing mobile dental care to all long-term care homes, along with a dental team, which consists of a dentist, an RDA, and an RDH, utilizing mobile units that can go bedside, chairside, for those that are homebound, bedbound, hospital-bound, facility-bound, due to either a physical, cognitive, or a combination of that perspective. We are lucky, though, in our 2 largest long-term care homes to have embedded dental units, which are philanthropically donated by 2 families decades ago. We provide our dentistry on a fee-for-service basis, following our provincially set fee guide, and also utilizing the home facility visitation code as we provide our care. Now, for advocating and lobbying, as mentioned, I've had several meetings within the past 2 decades with MLAs, Ministry of Health, long-term care administrators, Minister of Health in person, explaining our long-term care oral health care needs, the neglect that we're seeing in long-term care, and the dentistry demographics, just to explain to them that not every resident in long-term care has dentures. But even with all my meetings and my lobbying, basically we've had no assistance, no interest, and no developments in the last 20 to 25 years from our government. The past few years, though, I have been working with the Saskatchewan Health Authority employed part-time RDA or dental assistant employed as a long-term care oral health care coordinator. It is a position that we proposed, and our model for utilizing our long-term care coordinator within our model of providing care was that she was to do an initial oral assessment of all incoming long-term care residents and report to the resident and to the family of any oral health care needs. Then a referral to a dentist if it's necessary. This coordinator became the liaison between the dental team, the family, the facility, the MD, the RN, the care aides. And she was responsible for educating the oral health care, she was responsible for educating to the long-term care staff on daily oral health care. And she would ensure that daily oral care was provided to the residents with spot checks. Unfortunately, she's now retired, and the rumor is that because of course, fiscal constraints and COVID, that this most important position within our long-term care homes is not going to be filled. So that was a bit of a kick, but we're going to continue to lobby and advocate and see if we can have our long-term care coordinator returned. Our treatment at long-term care homes closely resembles an office setting model somewhat. We provide basic dental care to ensure quality of life. We treat active disease, inflammation in order to prevent pain, infection, and minimize oral source of the systemic inflammation. This usually entails 3 to 4 month hygiene visits from our RDHs that work with us, with silver diamine fluoride application and fluoride varnish application as well, which was previously alluded to. We provide basic restorative dentistry from using amalgam, IRM, and glass ionomers, minor oral surgery with removal of infected teeth or teeth that are problematic, removable prosto, and of course, this is all done with informed consents from the resident and the family, And we do utilize quite a bit of oral sedation as it is required. If I had a wish list for what I'd like to see to help us out, the first point would be is that our long-term care residents that are over 65 no longer are covered by basic dentistry that they would under the age of 65. And even lobbying with government to say that these low-income seniors should have basic dental coverage as other economically challenged individuals in the province have in regards to dentistry, but it falls on deaf ears, and our long-term care residents that are greater than 65 unfortunately have to rely either on family or their minimum income for the dentistry that we provide. I'd like to have the continuation of our oral health coordinator. In fact, I'd like to have coordinators all across Saskatchewan shared between different long-term care facilities. I'd like to have in-house allied dental personnel that provide daily oral care. We can teach our medical counterparts, the care aides, but the literature shows that the behavior that we can teach them will only stand up for about 4 to 6 weeks, and then again we'll fall back to I just can't clean his teeth because he doesn't want them cleaned, or he said or she said no today. So we need RDAs, we need RDHs embedded in our long-term care homes in order to provide daily oral care. I'd like to have mobile equipment available for practitioners across the province, for those that are interested but can't put the economic outlay to spend $5,000 to $10,000 on mobile equipment. I'd like to have new and upcoming long-term care homes to be outfitted with roughed-in plumbing for dental units. I think that, even just have the space available and have this the suction and the compressor plumbed in, which would be so easy then for dental equipment to go in. When I approached one of the people in Regina that actually designs and looks after the insides of new and upcoming long-term care homes, I asked them that, for the quality of life of our residents, would it be possible to do something like putting in roughed-in plumbing? And I was promptly told, or first I was asked that, is this something that a private person is asking for, or is it something that's publicly funded? And I said, no, it's for a private practitioner. And his response was, if it's anything private, there's no way that it's going to find any way into a publicly funded facility. So promptly shut down with that. I'd like to learn how to properly lobby our government, how to open eyes, how to educate. And I do wish that our CDA would be able to help us provincially with that, because I think group strength would maybe get some government on board with some sort of help. The other model of providing long-term care dentistry is a community clinic model, which I know is being provided in either 1 or 2 cities across Canada, which again is not a fee-for-service model, but again having a community clinic dentist that are able to provide dentistry to the vulnerable population group and possibly the long-term care homes, and I think would be a very, very nice model to pursue. Again, cost would be the limiting factor with being able to provide the equipment for that. I'd like to see more education provided by our colleges, the CDA, or dental schools for long-term care and geriatric care to not only dentists, but to students as well. And also, I'd like to see provincially establishment of long-term care standards for treatment guidelines for dental care for long-term care residents be put in provincially within our college bylaws and college act, just so that general practitioners know what is to be expected, what is considered standard of care for long-term care dentistry. I think with regards to my history with government and trying to get external help funding wise, both from a patient perspective and from a practitioner perspective, is that as long as we can continue to do dentistry where it doesn't involve any monetary contribution by our Ministry of Health or our provincial counterparts, or even our municipal government, they're welcome to it. But as soon as we ask for any sort of support when it comes to either working within the facilities or for equipment, then again it falls upon deaf ears, and we don't get a response. So our basic models that when I provide dentistry, when we go into our long-term care homes, we try to teach everybody to lift the lip. That's one motto that we've embraced, is that anybody that comes in, we invite and we ask everybody to at least lift the lip and see what's going on. And as alluded to previously, when we provide dentistry in long-term care facilities, less is more. So again, keep it simple, just like was said. It's all about basic care, keeping people comfortable, free of pain, free of inflammation. And as I said in my introduction, my hygienists that work with me and go into long-term care are the crux of my private care model. Is that as a dentist, I can't do it alone. I need my assistant, but our hygienists that go in and provide care on a 3 to 4 month basis for each resident is invaluable. And the improvement that we see in the oral health and in the quality of life of our residents is unmatched. So again, if you're going to provide long-term care, geriatric dentistry, you have to do it as a team. That's about all I have to present, and I will be more than happy to answer any questions.
All right, thank you so much, Dr. Bhargava. And finally, we have Dr. Nicholas Tong from the University of British Columbia. So Dr. Nicholas Tong is an assistant professor of teaching at the University of British Columbia Faculty of Dentistry in the Division of Prosthodontics and Dental Geriatrics. He's the program director for the hospital-based UBC General Practice Residency. Dr. Tong graduated with a BHSC degree from McMaster University in 2010, a DDS degree from the University of Toronto in 2014, a GPR certificate from the University of Alberta Hospital in 2015, and an MSc in Craniofacial Sciences from UBC in 2019. He's been a staff dentist with the UBC Geriatric Dentistry program since 2015, treating frail and functionally dependent patients in long-term care. Dr. Tong is a member of the Geriatric Dentistry Committee with the British Columbia Dental Association and a fellow with the Special Care Dentistry Association Council of Geriatric Dentistry. Please welcome Dr. Tong.
Thanks, Caitlin. Nice to see everybody, and I'm so impressed that 33 people are still here after an hour and 7 minutes, and that's great for all of us. Greetings from Vancouver. I'm here in Vancouver. As Caitlin said, I work at UBC, and I primarily work with the GPR program, which is based at BC Cancer Agency and Vancouver General Hospital, as well as with the Geriatric Dentistry program. So I think the comments that have been said by Christian and by Shaheen, Mary, Raj, I totally agree with everything they've said, and they've shared a lot of pearls with all of us, in the last hour, and they've touched on a lot of the high points. So I'll just share a little bit about my life, I guess, here in Vancouver. The program that I work with is the Geriatric Dentistry program, and it's a university-based program that was started in 2002 by my mentor, Dr. Chris Wyatt. So Chris Wyatt is a prosthodontist here in Vancouver, and his mentor before him was Dr. Michael McEntee, who was also a prosthodontist and a dental geriatrics researcher here in Vancouver. Our program has been functioning and serving long-term care facilities in Vancouver area since 2002, and we're also embedded into the university, into the faculty dentistry in such a way that we provide really 3 functions. We do the service piece. We treat older adults in long-term care. A lot of the long-term care facilities that we work with have embedded dental clinics, like what Raj was referring to. That is a real privilege for us, because that makes our job a lot easier when they have an actual physical facility, actually in the place. And I agree with everything that Raj said. Everything he said is totally true. For those patients from long-term care that don't have a dental clinic within their own facility, we offer them some services at the university, which in and of itself has a lot of challenges. Just getting out to the university, which is far away for a lot of people, so that's a huge barrier. So in any case, that's one of the 3 functions, is the service piece. The second piece is we teach quite a bit, and then the third piece is research. We conduct research out of our group. So those are the 3 pieces of our pie for the geriatric dentistry program. I'm mainly involved in the teaching and research end of it. So the teaching piece of it at UBC in Vancouver, we've been fortunate to be able to actually incorporate 2 courses in our curriculum. In the 3rd year dental curriculum for our DMD students, we have a full year course in geriatric dentistry. Sorry, it's a half-year course in geriatric dentistry in the 3rd year. And in 4th year, we have an additional course in geriatric dentistry. So we have 2 years of didactic content. In the third year, the clinical component of that course involves shadowing one of our dentists who works with geriatric patients and long-term care patients here in Vancouver. And they get a chance to shadow and assist one of our dentists working in long-term care. The clinical component of our fourth year course is they come with one of our dentists and they provide care at one of the long-term care facilities. So we've been able to incorporate both didactic and clinical components of that into our curriculum at the undergraduate level. And that's something that, we're quite proud of. And we see a lot of value in, especially, as this cohort of patients is, rapidly expanding in our country. There's, the increasing need, and well, that's why we're having this whole conversation tonight on this SPEA panel. So I'm also involved in the graduate level program, training, and most of the grad level training that happens in geriatrics happens through the graduate prosthodontics program, which is also run by Chris White as well, and that happens at UBC. And that's one piece, and then the other piece is our GPR residents. So our GPR residents come with me, and I'm actually currently in long-term care right now. We just finished our clinic day, so I'm sticking around to chat with you guys. As has been alluded to by Christian, Shaheen, Raj, and Mary, the times have changed. So times have changed in the sense that the type of people we're seeing in Canada are not the same as 30 years ago. 30 years ago, the average patient in long-term care was edentulous and had maybe dentures, and it was easy. And, when our program was first started, Chris Wyatt told me, he was like, he faced a lot of criticism from a lot of his, colleagues and from the long-term care facilities themselves. And they were asking, well, Chris, why do you even want to start a program? Why, there's no need for a dentist in long-term care. Everybody has no teeth. You just have dentures, what's the point? Well, times have changed. In the last 30 years, in the last 50 years, we've seen significantly decreasing rates of edentulism around the world. And we've certainly experienced that in Canada. Our patient pool now is very dentate. And because of this, there are massive levels of oral disease that we see in our patients. And we deal with all the same problems that were alluded to by Shaheen, Raj, Mary, and Christian. Patients with functional impairment, patients with physical decline, patients with cognitive decline. So, this whole concept for us and, for all the dental students that are here on the talk tonight, I guess the pearl that I'd like to share with you is, when you work with geriatric patients, and you guys do work with a lot of geriatric patients in your student clinics, at Western University, at the University of Toronto, at Laval, and all these schools across Canada, a lot of your patient pools are already geriatric. Well, there's a lot of clinical heterogeneity amongst geriatric people in our society. There are the functionally independent folks, there are the frail folks, and then there's the functionally dependent folks. Most of the people that we're alluding to tonight that live in long-term care are in that last category. They're functionally dependent on others to help with their activities of daily living or their instrumental activities of daily living. So most of the folks you guys as students deal with are probably in that first two categories, in the functionally independent or maybe the beginnings of frailty patients. And those patients still, we need to remember that accounts for most older adults in our country. Most older adults are still somewhat robust, able to live by themselves with maybe a little bit of support at home. The people that are functionally dependent only account for a small percentage of the older adults in our society. But these are still important people in our society, and they do need to be cared for by people like the people that you see on the screen here with us on this panel. And hopefully more if we can get you guys interested. So I guess, I don't want to say too much more, because I'd like to save some time for questions. But I guess, if I'm going to give some advice for young people, for dental students, and I guess I'm sort of a young person too. So I guess, you guys are my generation. But, I guess my advice for young people would be, well, we need young people in our fields. So please come join us. If you guys have an interest in geriatric dentistry, please contact one of us and we will get you guys involved. Please contact, the established geriatric groups around our country and get involved with our programs and get involved with continuing education, get involved with formal training, postgraduate training, if you'd like to, advance your didactic and clinical skills to deal with this population. my own sense is that, when folks graduate out of, their fourth year dental school, it's really intimidating to treat someone in long-term care. It's scary. Like, they're sick, they're agitated, they're aggressive, they're spitting, they're fighting you, they're punching, it's like, that's scary as like a young person. But, there's a lot of pearls that have been shared by our panel tonight. There's a lot of ways to make life easier. And there's a lot of ways to change and modify our treatment plans to make it doable, make it realistic. Like, do something that actually will, as Shaheen was saying, do something that will be a benefit to this patient. And there's ways that we can modify our treatment plans to actually do something that will, be actually meaningful to these people. So my advice is, get involved, contact one of us, and please join us. We would love to have you join us if you have the passion for this. For those folks and most people that go to dental school, they will end up in private practice. So I guess for the private practice person, make your office as senior friendly as possible. So there's a lot of things that we can do with that, wheelchair accessibility, having, your receptionist being welcoming. So older adults in the practice, being sensitive to, sensory loss with hearing loss and vision issues, having wheelchair overhead lifts to move patients safely from wheelchair into the dental chair. This is not a very common thing that we have, but is for me, and we have the privilege of having that in our long-term care clinics, our dental clinics within long-term care. That makes my life so much easier when I can transfer the patient safely with a sling underneath their bum and transfer them safely from their wheelchair into my chair, because then I can actually do my extraction or do the GI restoration or whatever I need to do. So in any case, I will stop there, and I'm also happy to field any questions. Thanks, Caitlin.
Great, thank you, everyone. And so thank you very much to all of our speakers for your wonderful talks. And so now we'd like to open the floor for our panel discussion. And so I do have some questions that kind of arose from things that you all brought up. So one question I have here is, a few of you mentioned that patient behavior with geriatric patients can be a challenge, and it can become especially difficult, when combined with other medical conditions and cognitive decline, such as in Alzheimer's. So what tips do you have related to patient management? And feel free for any of you to chime in. I mean, you don't all have to respond, but if you have anything you'd like to contribute, please feel free to chime in anytime.
Yeah, Caitlin.
Okay.
Oh yeah, maybe I'll let Shaheen start.
No, go ahead. After you.
Yeah, okay, well, I'll just make a brief comment then, Caitlin. It depends what the patient's like, and it depends what you want to do that day. So it gets more sophisticated, or maybe, like we employ different techniques based on what we're actually trying to do maybe that day with the patient in the chair. One way to conceptualize it is, well, look at what our pediatric dentistry friends are doing in terms of basic behavior guidance versus advanced behavior guidance. There's a time and a place in my mind for all those basic behavior guidance techniques like tell, show, do, ask, tell, ask, sensory adaptive dental environments, positive reinforcements, all these different techniques that our pediatric dentistry specialists use. And then a time for advanced behavior guidance techniques like protective stabilization and sedation and all these other things. So there are a lot of behavior management techniques that can be employed and that we teach in our graduate programs. And well, I guess the smart and prudent practitioner employs them. You got to use the right technique with the right patient at the right time. Okay, and I will stop there.
No, that's pretty much it. I really agree with all of that. I think the other thing is to make sure that when you're engaging with the patient that is quite difficult, that you speak directly to them and very, very clearly, not in complicated language. And basically, I think if you talk with one of the most important things that I've learned over the years is if some patient comes in and they are sleeping, don't wake them up, because they can become, and if they have Alzheimer's, they can become very aggressive. But I think basically, you have to be very open to using all of the techniques that Nick has mentioned. And simplistically, if it's a situation where it's very difficult for you to do anything, you reschedule. That's the basic. You don't push it. You don't force anything. you just reschedule and hope that they'll have a better day. You can talk with their caregivers or the nursing home to find out what's a optimal time when they're actually able to tolerate what you're going to do for them.
What we do in Saskatoon is the initial assessment is done when you kind of do their checkup. So you see what nature that patient has, just by going into their mouth and moving their cheeks and looking, you can kind of see what their reaction is going to be once you actually start to try and do some dentistry for them. We also work closely with our physicians that are on staff with every long-term care home. So if we do feel that sedation is something that would be of benefit, and we do use oral sedation a fair bit, then we consult with their physician and asking them that for dental treatment, we'd like to have prior sedation. And then we along with the physician, we titrate the sedation. We try a little bit beforehand and then see if that's enough, maybe go forward, sometimes time of day, but exactly is that some days they're on, some days they're off. So if you can't accomplish something one day, you try another day.
One thing what work well also is for the Alzheimer's disease patient is you have to occupy their mind. So what I'm doing is I'm talking constantly during my work, and I tell them every gesture that I will do in their mouth. So then they hear that, but during the time they do their reflection on that, they are not reactive. So it works well when you talk a lot, and then they are less aggressive then.
I always make sure to start my care by getting down to, if they're in a wheelchair, down to their level, and making sure that I give them some type of reassurance that everything, that they're safe. And I usually start with a face hug and before I start. And so I feel very fortunate that I worked 13 years in a pediatric office before I transitioned to long-term care and working with geriatrics, because let me tell you, I used everything in my toolkit some days, to be able to to have some success. So, but like the others had said, some days are good and some days aren't that good. So, but yeah. And I think when you're sincere and you're wanting to create that safe environment, who you're caring for can feel that as well.
Perfect. All right. So some of you talked about determining what treatment might actually be feasible for a patient. And in some cases, that means just providing basic care to keep the patient comfortable. So how do you grapple with finding that balance and possibly coming to terms with forgoing what might perhaps be the ideal treatment versus what might be considered more realistic?
Caitlin, yeah, that's a good question. There's a good, there's a pretty well-known researcher from the University of Iowa. His name is Dr. Ettinger, who's a prosthodontist in the US, and he's now retired now. But one of the concepts that you're alluding to in your question is the concept of rational treatment planning. So I would suggest for anybody interested here, he's written a few good papers. His name is Dr. Ettinger, and he talks about this concept about rational treatment planning and talking about the clinical algorithm that that experienced clinicians go through when they think about to come up with what we call a rational treatment plan, and how that differs from quote unquote an academic treatment plan. So an academic treatment plan is what we're taught in dental school. Phase 1, disease control, make sure the teeth and roots are perfectly scaled and root planed, and then restore all the caries, and then remove all the infected teeth, and then rehabilitate the occlusion with fixed prostheses. Well, that's not practical sometimes, oftentimes for us in our settings. So in any case, it's a long question, and I would say, yeah, there's some good discussion about that already in the literature. And maybe one place to start is this whole concept about rational treatment planning and how it differs from academic treatment planning. And it does. It also brings into the whole consideration, about all the factors that we've all talked about today, the social factors, the family factors, the behavioral factors, the dentist's ability to actually do the care, all this other stuff. So they talk about that in their algorithm, in the diagnosis treatment planning algorithm described in those papers.
Another thing is that, the guidelines that we learn as good care, sometimes, they do not apply to the geriatric patient. Sometimes that teeth that you could save on a younger and more cooperative person, these teeth, you won't be able to keep it. And, that's one thing that you consider, that, the guidelines that you learn may not be applying to that population all the time.
And Caitlin, just one last comment too, that's a really good question that you asked, because this is actually the part that young people feel most uncomfortable with when they graduate from dental school and they're treating these people. Because, when we graduate students from our school, they feel very uncomfortable with what I would consider a rational treatment plan sometimes, because in their eyes, it feels like you're doing subpar service, like you're not providing good care. But, and I see a lot of heads nodding here in our panel, it's important for us to rationalize why we are suggesting this type of plan and, come up with rationale why we're doing what we're doing and how we're doing it. So this is important because real life is not like dental school. Real life, in long-term care, there are real challenges and barriers that are not the same as your healthy, young, perfect young guy or girl. And the prognosis of what we do is not the same. Yeah.
I think our secret is, again, to keep it simple. And also remember the fact that you want to try and keep your patient pain-free, inflammation-free. Stick to basic dentistry. Again, coming out of school, you have the ideal ingrained into you, and long-term care and geriatric is reality. So if a new practitioner wants to spend time with a veteran practitioner that provides long-term care or geriatric dentistry, it won't take long to see the treatment planning, the diagnosing, the actual treatment providing as how different it is from what you learned in school. So maybe spend some time with a geriatric dentist or a long-term care dentist and ask a lot of questions. And it doesn't take long to learn. And Dr. Edinger, we had him up in Saskatoon for a presentation a few years ago. Just a great presenter and very correct. Any of his articles are worth reading if you're going to provide any sort of geriatric dentistry.
I totally agree with all of the panelists. I think it's one of the basic things to remember is that you really learn dentistry when you're in practice in the first 6 months after you graduate. You learn reality, and it's not a perfect world. But the most important thing, I think, is to know your patient, to know what they can handle. And that only comes by trying to push it and see, can I do this? Can I do this on this patient? And if it goes too far, then you withdraw and reassess and then redo. So I think it's a learning process, and the learning process comes in when you are dealing with a patient and how that patient reacts to you. So I think that's my takeaway right now, is just make sure that you're focused on what the patient can tolerate.
I have a follow-up question from somebody in the audience. So they said Dr. Edinger has advocated for the development of a geriatric dentistry specialty in Canada. Is this a solution to improving access to geriatric care, or would more government funding be a better solution?
Yeah, maybe Christian, maybe perhaps you can go first.
Yeah, in Quebec City, we developed a model of care which is governmental funded, and they allow $10 million a year to the program, and they put like hygienists in every nursing home, dental hygienist, not full time, but they are visiting at least, I think, a day a week or half a day a week. And the care, some of the care are paid through that amount of money, but it's basic care only. But the question is it should be publicly or privately funded? I would say that the government should do their part, because these people need care, and if we leave it only to private pay for fee service, I think, you know, the worst of the people, that the people in the worst condition will get less care, and the people may go only to the easier patient to treat. So I think the government have to be at least a part of the solution.
And Caitlin, I'll also answer the other part of your question. And I know Dr. Rucker also had his hand up, and perhaps he can ask his question after I finish. You also asked the question, you know, well, should governments partially pay for service? Yes, I agree with what Christian said. Certainly there's an element where reducing that financial barrier to care will help a lot of older adults in our society. The other piece of it, though, too, is you said, should we create a dental specialty in geriatric dentistry? Well, that's a very loaded question. There's a lot of elements to actually creating a specialty in Canada, and there's a lot of components to that. And, you know, Dr. Wyatt and I are actually, you know, currently in the initial stages of sort of exploring what that actually might mean at the graduate level, about creating curriculum, creating a actual graduate diploma or certificate program recognized by an accredited university to do that. But, you know, what we're seeing now in terms of the dental complexity and medical complexity in the community, I think can essentially justify graduate specialty level training, because the type of patients we're dealing with are, well, frankly, beyond what the average general practitioner probably can do, because some of the patients are quite complex. And, you know, this is not like maybe all geriatric patients, but there are a small subset of very complex geriatric patients where if we had someone with specialty level training, this person could be used as a consultant for our dental profession and a referral person that could be engaged for these complex cases, which is like how other certified specialists in our country are engaged, right? We engage them for complex cases. So whether or not this will happen in our lifetimes or whatever, I hope it does. But, you know, like what your question was asking, well, there's a lot of, that's a very loaded question. What would this person do? How would they be trained? How would they be accredited and certified? Who is examining them? You know, what does a specialty even mean? Like, and what function do they serve in our profession? Well, these are very existential questions. And I would love to speak for hours with any of you if you guys are interested, because I think about these things a lot. But in any case, I'll stop there, and perhaps Dr. Rucker can ask his question.
All right, may I, Caitlin?
Yep, go ahead.
Thank you. I really appreciate the excellent range of profiles that each of you have offered of the geriatric patients who are referred to you and with whom you work, and your recognition that this is probably the more challenging to manage range of geriatric patients, and yet you have spoken to the issue that it is a full range, and it's always challenging to new graduates, I think, to perform any sort of assessment of individual competence of the patient, of the individual complexity of their treatment plans, just as it is in some of the other specialty areas, to know when to refer to where they can refer. So yes, that same comment, observation of what you have said, I think applies to all practitioners. To the more, to the simpler practical question, I suppose, I have noticed over the years the difficulty that not only new dentists, but particularly new dentists have with doing an assessment of patients who have some early psychomotor limitations, who may have a certain motivational limitations, though most often psychomotor limitations, I think, and may or may not have ever been particularly well trained in care for their own mouths anyway. And those who have a caregiver who has come with them, it may be a family member, or it may be a nurse from an institution, so the challenge would be, to me, and I think to many others, is that how can you enlist optimal oral care amongst well-meaning caregivers who have not been trained to brush or floss or assess another person, perhaps even themselves. And I would include care home nurses here.
I'll take a, I'll jump into that. That is definitely, that is the challenge. And depending on the needs of who they are caring for and their own abilities to do the care. And lots of times, it is their partner potentially that's bringing them into the clinic for care, and they may have their own struggles as well. And I think the most important thing is to demonstrate that they're safe in providing care. Their fear is of being bitten, right? They're scared that they're going to be bitten, and then they're potentially scared as well because the tissues are bleeding. And so I think that having that conversation and showing some simple ways of providing, and we keep it simple as well. We just start with basic toothbrushing and using toothpaste with fluoride, and how much toothpaste to use and how to wipe and brush as you go, so that there's no need to rinse the mouth. Because as most residents or older adults sometimes have issues with swallowing, so they have dysphagia. And so how can we safely provide that? So again, it is assessing the abilities of the caregiver, whether professional or family, and it's assessing what are the needs of the person that needs care, and how to do it. And it is that safety, and it's addressing how to you can easily get into the mouth and demonstrate how it is. So when I have some challenges, get some pushback on that it's such a challenge to brush your teeth, I will also then respond with, I'm in here with very sharp instruments and able to safely provide care. And so if I can get in with very sharp instruments and safely provide care, I can show you some tricks and that. And so I think that the concept of that's why I started with the brushing. The concept of brushing teeth seems very straightforward and simple, but it isn't easy to brush somebody else's teeth. And so there is a skill set. And when you can show that and demonstrate some tricks and there's great tools to use, it's just that having that opportunity to demonstrate and show does take some time.
I think we sort of instituted a program at Sunnybrook in our long-term care, but we used an interprofessional team, which was composed of nurses, speech language pathologists, and nurses aides, and of course, dentists and doctors. So we provided education for them, and we keep providing education for them. The biggest thing is that they are afraid. One of the biggest barriers is that they're afraid that they will hurt the patient. And the second barrier is they're afraid that they'll get bitten. So we use these teaching, continuing education programs in order to keep that active, keep that oral care active and on the radar, so that it doesn't get neglected. And often after a while it does. So we usually have one of the nursing managers call us and say, could you come down and refresh us? So we just do that, go and talk to them briefly about it and how to do it with pictures and examples and all of that. So the bottom line is that you have to provide education for these caregivers, for the nursing aides, and for the nurses. And there has to be a willingness on part of the organization of nursing homes to allow us to do this. And so if we don't have an interprofessional team, which I found after 30 years that it only works if you engage the other medical professionals that are providing this care, and then it can work very well.
Okay, great.
Thank
So
you.
this kind of
Thank you all. And I suppose I was looking to, and I think you've answered, looking to general practices who are seeing patients before the institutions have been engaged, before the tertiary care folks have come into play, to hopefully diminish the curve of any decline that might be there for home care, for continued care. And I know it's a real challenge. It's a real challenge because by and large, we work with children, young children whose parents have much difficulty understanding how to go about cleaning their mouths properly. So thank you very much.
Well, just to continue with what you say very briefly, is that for sure most of the important treatment should be done at the early stage of the cognitive decline. Then should be more preventive, very aggressive preventive care to be sure that we maintain the people, not reconstruct, but maintain them till they go away. So that's one thing that is important for the dentist works, early on with these people.
This question is kind of continues on to something that Dr. Tong mentioned earlier. But for students who might be interested in treating geriatric patients specifically, so for example, long-term care homes, how can they go about getting involved in that? So does that require additional formal training, or are there other ways to get involved?
I'm not sure if I understand well your question, or if you would talking too fast for me, but could you just repeat, because I think more slower, so maybe I can answer that question.
Yeah, sure. So for students who might be interested in treating geriatric patients specifically, so say, for example, becoming a dentist who goes to a long-term care home to provide care, how do they go about getting involved? Does that require additional formal training? So for example, doing a general practice residency, or doing one of these geriatric dentistry programs in Canada, or are there other ways to get involved?
Okay. I would take from my experience what we've done in Quebec. We develop training for the dentists who were interested in the long-term care. The government choose some of the dentists to work in the facility, and then they train them. I developed the training. It was a electronic e-training, okay, for them, and they had to succeed there's an exam. But I think a person can treat people even if they didn't get trained, but they need to understand well, okay, by themselves, how the people that gets cognitively impaired problem, because in nursing home they will face that every day. Most of them have this problem. So I said, I think legally you can, but it will be more you get more reassured as a professional if you get more training. It shouldn't be necessarily a specialty training, but they should get at least some of the training to understand who is these people that they are treating in terms of behavior. At least.
And I know at USask, the dental students get a little bit of didactic training in geriatric dentistry. And then they're also come along with me when we go to our long-term care homes for a couple of afternoon or morning sessions, just to give them that experience. And then they're always told that they're welcome to join the team, either myself or the hygienist, when we go to long-term care homes, in order to give them a little bit more experience. And again, courses, CE courses in geriatric dentistry are available across North America, and you have experts. And I think, when you're looking at going into a larger facility like Sunnybrook or like one at UBC, it's a little bit different from a resident perspective. When you're providing general practice geriatric dentistry like we do from our practice, we again cannot do the more complex cognitively impaired patient, or the complex dentistry that might be required in some specific situations. But being able to provide decent care for the majority of our long-term care residents, as a GP, I think GPs, as was just previously said, are more than capable of providing geriatric dentistry.
And then to follow up with that question, though, so you mentioned general practice, and majority of people graduating from dental school do go into general practice. So for new grads who are going to be general practitioners treating geriatric patients, what can they do to become more comfortable with treating geriatric patients?
Well, what we found is that if some students who are really interested, they've when I was working at the UFT, they would contact me and say, could we come and do an elective during the summer? Could we just come and hang out with you to see what's happening? So that kind of thing was very, before COVID, was very, very popular. But with COVID, we've had to shut all of those trainings down. And we also had, in third and fourth year, they come through a rotation through to see hospital dentistry and to see dentistry, geriatric dentistry. So we have that. And I always encourage all of my past students to, if they have any issues with geriatrics, if they need any help, to contact me, and I would be very happy to kind of help them with that. And then again, continuing education, as Raj said, that would be the way to go.
Okay, perfect. We are running a bit over time, so I'm just going to ask one final question to all the panelists, and you feel free to each give your responses. It's kind of a combined question because I also got a question from somebody in the audience. So they are asking, what motivated you to get into geriatric dentistry? And then the combined question would be, why should new grads and students get involved in geriatric dentistry? And what advice do you have for our dental students?
So I can probably start. Geriatric dentistry and mobile dental care interested me from the year I graduated. It was 1988, because at that time I knew there was a need, and I knew something as mobile dentistry did not exist. So that's how my interest in geriatric dentistry started, was providing mobile dental care. And then that evolved kind of naturally into long-term care homes when I saw that, again, unable to get dental needs in those situations, that mobile care may be able to fill a niche there. So that's how I got interested. And for new students when you look at Saskatchewan and you look at underserviced and access to care issues, rural areas across Saskatchewan, definitely require dentistry. And you look at long-term care, and our long-term care dentist residents definitely require dentistry. So it's an area that I'd invite any dental student to get involved in. But again, you have to. I would invite them to join a practice or have a few practitioners with them, because as a team, it's a lot easier to service one or two long-term care homes along with private practice, because long-term care dentistry is not a moneymaker. You don't do it because you're gonna pay a lot of overhead. You don't. We do it, and we're able to do it because we are a large practice, and my partners allow me to leave 1 day a week and take interested staff with me and provide care. I also feel like I'm a veteran dentist. I feel it's my obligation from an ethical perspective to give back to our patients that came to our office over a number of years, and now out of no fault of their own, they're unable to seek dental care in the regular fashion. So it's a way of giving back from a private practice perspective.
My interest started when shortly after I graduated in the UK. And in the UK in the early 80s, they started a program for seniors in community and public health settings. And I was sort of kind of drawn to that. And then I engaged with seniors and found out that they were charming people, wonderful people to work with. And then the biggest thing is the challenge. Routine dentistry can become a little bit boring, sort of, but working with seniors, with the managing them, with the complex issues, it kind of is very challenging. And it's once you've done something well and it's worked out for that particular person, the satisfaction is enormous. It's quite inspiring to be able to do that for someone. And then this age group, they're very grateful for whatever you do for them, very appreciative, extremely kind people, and very, I would say, well-mannered. Sometimes we see people who are very aggressive out in practice, but the kind of people that we treat are very, very gentle people. And it's very, I encourage anyone who has communication skills with patients to engage in geriatric dentistry, because you'll find it's very fulfilling and enjoyable. And so I wish you all the luck and hope that you will be engaged with geriatrics. Thank you.
For me, it was a different story. You know, when I started to be interested in geriatric dentistry, I was in private practice and was treating older patients, but that was very autonomous and very better, you know, the health were not that good, but you know, they were very cooperative, they were brushing their teeth. And at one point, I had some patients who were missing their appointment repeatedly. And then I was questioning what happened to you? You know, I was even angry to them because why can you respect, you know, the appointment? And then it was an opening at my university as a professor. So I've been there and went to the specialty training program in Boston. But, you know, as I said, I didn't know what I would be facing, you know, because, you know, that when I was in private practice, I haven't faced this kind of patient. They were not coming to my office. They were in nursing home, they were homebound, but you know, but then when I seen that, I seen there were a big needs, preventive needs to try to download the burden of disease that were in their mouth, you know, and facing people that were challenging. But you know, in a way, you know, I was very afraid at the beginning, but you know, since I knew them and knew their behavior, I was more able to not to control them, but to interact with them and make them have it to cooperate. But that is very interesting, and it's a challenge. And also, you don't do that only for money. You need to do that because you like this patient. You have to love this patient, and the more you love them, the more they will help you to succeed the treatment you're doing to them. Thank you.
For myself, it probably was my, my instructors who, it was on a rotations that we would go to long-term care facilities, and it probably was my experience. I was a dental assistant before, and like I said, I worked in a pediatric office, and they identified that, I had some comfort in the ability to communicate, like it was mentioned, and I was tapped on the shoulder after graduating to, take on this position at the university. And, it was very challenging. There's things I would see, and I didn't know what was happening, and it was never a dull moment. And the interactions with the patients, clients, at times was very challenging, but then there's the reward. And I think it's the reward that, just keeps you going, and that, because it's not easy work, and physically it's demanding. But there's just something about it. And you're right, like there isn't a dull moment. Like there was you never knew what was going to happen. And you just, I guess that keeps a bit of an excitement to it. And I enjoyed the challenge. I enjoyed the challenge of, someone who had never, received dental hygiene care and actually couldn't really even like lower their tongue because the buildup of calculus was preventing that. And how was I going to remove that safely? And who should I call as my backup on the team, when I was trying to remove that lump of coal size of calculus. But then the relief that this individual was able to relax their tongue, like those are it's very rewarding. But and it can be scary, but I think that there's a lot of good mentors out there that will be grateful to share and pass on the knowledge. So hopefully this will entice some to go into the geriatric side of things.
All right, well, hopefully, yes. Thank you. After all your wonderful presentations, hopefully we will have some students who might be interested in going to the field in the future. So thank you, Dr. Nicholas Tong, Raj Bhargava, Mary Bertone, Shaheen, Husain, and Christian Caron for taking part in our event. We truly appreciate all the work you do, and your contributions to our discussion tonight and the insights you shared with us. It was truly a privilege to hear and speak with you all. So thank you for being part of this. I'd also like to thank the American College of Dentists for their generous support. Thank you to the SPEA Canadian chapters for their help with recruiting panelists. And thank you to the SPEA Schulich team at Western University for their help behind the scenes. And finally, thank you to all of you for joining us tonight.
Thank you, Caitlin, for organizing it all. Thank you.